Assalamu alaikum. Good afternoon, everyone. Welcome to our academic activity for today. So we'll start our activity with lecture by Dr. Abdul Hadi Al-A'ma about surgery for adult congenital heart diseases. We'll start, inshallah, 5 minutes from now. Abdul Hadi.
عليكم السلام.
Yes. عليكم السلام ورحمة الله.
تفضل.
بسم الله الرحمن الرحيم. السلام عليكم. Good afternoon, everyone. أنا عبد الهادي الأعمى, R2 cardiac surgery, and my topic today is about the adult congenital heart diseases. To start with the outlines that I'm going to go over. First, I'm going to talk about the re-operative sternotomy, then the atrial and ventricular septal defects. We'll mention about the Ebstein anomalies, the Fontan revisions, RVOT and LVOT reconstructions, arrhythmia surgeries, and the coarctation of the aorta, and some management for the interventional devices. The re-operative sternotomy. Congenital heart procedures in adults are frequently re-operations. However, they often prove more challenging than acquired heart diseases and carry a higher risk of trauma. Femoral cannulation is rarely used in the adult congenital heart disease patients because most of them have undergone multiple interventional catheterizations during their growth years, resulting in stenotic or occluded femoral vessels. The highest risk for adult congenital heart disease operations include retrosternal ventricular to pulmonary artery conduits, particularly if they are calcified or have multiple stents in place or are clearly embedded in the sternum. Fusion to the sternum should always be suspected when the conduit does not move with the cardiac cycle on the lateral angiograms. Right ventricular enlargement also carries a high risk for traumatic sternal reentry. Prior sternal infections, aneurysms of the right or left ventricular outflow tract, pectus excavatum, or aortopulmonary shunts. Patients with multiple risk factors may be placed on bypass to decompress the right ventricular prior to sternal division. The steps of the re-operative sternotomy. The previous sternotomy scars are excised and the sternal wires are removed. The xiphoid process is removed and carotid dissection is begun at the inferior sternal edge. The oscillating saw can be used to divide the anterior sternal table. Retractors are used to elevate the two sides of the sternum and expose the retrosternal scar. Short segments of retrosternal scars are released, followed by gradual sternal division, with the oscillating saw proceeding up to the sternum. In the event of a cardiac or great vessel penetration, when no vessels for cannulation has already been exposed, an immediate extension of the incision is performed up to the neck and to the right to expose the innominate artery and the internal jugular or high innominate vein, and bypass can be initiated from there. Another option is to dissect the inferior vena cava just above the diaphragm. The atrial septal defects. It's the most common congenital cardiac anomaly in adults. The transcatheter device closure for ASDs has significantly changed the average surgical case volumes. Patent foramen ovales and most secundum defects are effectively close to the device in the cath lab and are rarely referred for surgical closure. Sinus venosus and primum defects, transitional and complete AV canal, common atrium, and secundum defects with deficient inferior and superior rims are referred for surgery, and we repair these on cardiopulmonary bypass with bicaval cannulation. Multiple incisional approaches have been described to improve the cosmetic results and reduce operative trauma, including partial upper and lower sternotomies, transxiphoid or anterior thoracotomies, and submammary incisions. However, median sternotomy is still considered the safest, despite the visible scar. Almost all septal defects that require surgical repair and cannot be closed in the cath lab are best repaired using a patch. For the sinus venosus defects, a right-angled cannula can be placed in the anominant vein to enable exposure of the partial anomalous pulmonary veins entering the superior vena cava. The atrial incision extended superiorly to a point above the entrance of the highest anomalous vein, and the patch is used to close the atrial incision to avoid superior vena cava stenosis. In patients with premium ASDs, the cleft mitral valve is routinely repaired with fine running proline suture, approximating the line of contact between the leaflet segments. Even patients with competent valves are repaired, as late onset of cleft regurgitation is known to occur. Patients at risk for mitral stenosis, particularly those with a single papillary muscle in the left ventricle, may have their clefts left open to avoid valvular stenosis. The ventricular septal defects account for only 10% of the congenital heart defects in the adults because many close spontaneously. They are classified into 4 groups based on the size of the defect. Small restrictive VSDs are associated with small left-right shunts, and there's typically no LV volume overload or pulmonary hypertension. The moderate group typically measures more than 25 but less than 75% of the aortic annulus diameter and results in mild to moderate volume overload of the pulmonary arteries, left atrium, and left ventricle. Patients with this lesion typically have various degrees of pulmonary hypertension. Large non-restrictive VSDs with a diameter of more than 75% of the aortic annulus, if left uncorrected, can go early on into pulmonary hypertension. These are usually closed during the first year of life, and this, of course, if left uncorrected, it can cause Eisenmenger syndrome with right to left shunts. Some adults with prior VSD closures have a residual VSD, but this can be hemodynamically insignificant. The management of patients with VSD depends on the type of defect, its size, and the resulting magnitude of shunting, and is associated with acquired complications. Most patients with small asymptomatic and complicated VSDs require only medical management, although some develop complications later on. VSDs are closed when there is significant shunting with pulmonary hypertension, or if there's a worsening in the aortic regurgitations, or if there's a history of infective endocarditis. To move on to the Ebstein's anomaly. Surgery for the Ebstein's anomaly in older patients carries low risk and good late outcome. The operation is comprised of tricuspid valve repair or replacement and concomitant procedures such as ASD closures or arrhythmia surgery and CABG. The presence of an untethered and well-developed anterior tricuspid valve leaflet increases the chance of a successful repair. The cone technique has been used in adult patients with success, and the ASD is partially closed. Fontan revisions. Fontan patients may present with arrhythmia and complications related to systemic ventricular failure, protein losing enteropathy, systemic venous pathway obstructions, and semilunar and atrioventricular valves dysfunction. Initial evaluations must focus on ensuring a completely unobstructed vascular pathway to the lungs. Patients with intracardiac baffles and atriopulmonary connections may present with extreme right atrial enlargement, resulting in a stagnant flow, right pulmonary vein compression, and arrhythmia. Fontan conversion involves takedown of any venous connection and creation of an extracardiac cavopulmonary connection with a conduit. However, because the extracardiac Fontan excludes the systemic veins from the heart, any catheterization procedures requiring access to the atria is must be planned before the conversion, especially the electrophysiology interventions. Therefore, Fontan revisions are frequently combined with arrhythmia surgery and treatment of atrioventricular valve dysfunction. Valve repairs are often complex in these patients, and replacements are often required. It depends on the patient's anatomy and ventricular functions and pulmonary vascular resistance. The participation of the electrophysiology team in the Fontan revisions ensures effective interruptions or ablation of all re-entrant pathways, which may not follow the patterns seen in patients with acquired heart diseases and normal cardiac anatomic relationships. A variety of MACE procedures have been described to disrupt atrial re-entrant pathways. The unpredictable anatomy of the conduction tissue in the adult congenital heart disease patients have resulted in a recommended routine placement of a dual chamber anti-tachycardia pacemaker. The RVOT reconstruction. RVOT reconstructions after previous repairs of tetralogy of Fallot or double outlet right ventricles or pulmonary atresia or truncus arteriosus or arterial switches, they are increasingly common to require RVOT reconstructions later on. These patients who underwent successful neonatal and infant repairs, they usually return with pulmonary insufficiency or stenosis, causing right ventricular dysfunction. They can also experience exercise intolerance, arrhythmias, and sudden death. The transcatheter pulmonary valve insertion is growing these days, and it can provide a good alternative. It can be placed or on the reconstructed RVOT, and it can be placed on homografts with the surgical team being on a standby in case of ruptured patients. In case the patient ruptures, the surgical team can go in and place the patient on an emergent bypass, and they can go with surgical repair. And these have shown good results. Patients who are not suited for the transcatheter valves, the only option left is the surgical reconstruction. The median, this is done usually using a median sternotomy with bicaval cannulation and bypass with moderate hypothermia. If there is a previous right ventricular incision or patch, this is considered a safe spot or a safe re-entry point. And the incision can be taken there. The incision is extended to facilitate inspection of the right ventricle and allows resection of the obstruction muscle bundles. The pulmonary valve replacement options include pulmonary and aortic homografts, bovine jugular vein grafts, bioprosthetic valves, and mechanical or prosthetic valves. The distal pulmonary artery anastomosis is done using the running 6-0 Prolene suture. Trimming of the proximal homograft muscle cuff to match the right ventricular incision is done next. When the proximal anastomosis is being constructed, it's important to take care to avoid injury to the left main and the anterior descending coronary artery. When these cannot be visualized due to epicardial scarring, intraoperative fluorescent imaging can be done to map the coronary arteries on the surface of the right ventricle. The anterior wall of the or the anterior portion of the RVOT is completed with a patch of native or a bovine pericardium. Bioprosthetics and mechanical valves are positioned in the right ventricular outflow tract at the normal pulmonary valve annulus in patients with normal LV anatomy. Compression of the left main coronary artery must also be considered when positioning these rigid valve rings, as we mentioned earlier. The valve suture line must be constructed so that the valve orients parallel to the main pulmonary, avoiding the tendency for the valve to aim up towards the sternum. It is important to make sure that the valve struts do not obstruct the branch pulmonary artery. If the implanted valve does not fit in the native outflow tract, because its outflow tract is too small, then a patch may be used to close the main pulmonary artery and infundibulum, make it a little bigger. The left ventricular outflow tract reconstruction. Isolated left ventricular outflow tract obstructions is less common in the adult congenital heart disease patients than in the acquired left-sided lesions. Patients with Schoen's syndrome often undergo numerous surgical and interventional procedures over their lifetime, and these interventions are at best palliative. Adult congenital teams must be prepared to perform primary ROS procedures or ROS cono and cono procedures, and they have to be able to deal with the re-operations for each of these palliations. The ROS operation is often used in pediatric patients with complex left ventricular outflow tract obstruction to treat combined valvular and supravalvular lesions, and to avoid the need for the anticoagulation and maintain some growth potential. These patients may require adults to replace or repair failing neo-aortic valves or stenotic or regurgitant pulmonary valves. Follow-up of the right ventricular reconstructions after ROS procedures show that 4% of patients will require conduit replacement of the for their right ventricular dysfunction at 10 years. Conduit size less than 14 millimeter is an independent predictor of allograft dysfunction. However, the availability of the percutaneous aortic and pulmonary valve options may increase the utilization of the ROS operations, as the re-interventions on the autograft and allograft may not require re-operations. The cono-aortic ventriculoplasty, which is aortic annulus enlargement by incising the aorta and extending the incision to the RV interventricular septum. This is used to treat complex LVOT obstructions and may be performed in adults who require initial treatments or reoperations for valve malfunction or outgrown valves. The Rose cono utilizing the transplanted pulmonary autograft with a ventricular septal patch or infundibular extension. This has been shown to increase in size as the patient grows, making this an excellent option in small pediatric patients. Reoperations after Ross or Ross cono or cono procedures is challenging, especially if the right ventricular outflow tract has been reconstructed with a large patch, because this patch usually covers the anterior aortic wall. So the exposure of the aortic root necessitates re-entry into the right ventricle. Given the high incidence of reoperations on these patients, anti-adhesion barriers are recommended. Arrhythmia surgery. Maintaining a functional conduction system is a crucial aspect of reducing the cumulative lifetime trauma for congenital heart patients. Despite these efforts to prevent the conduction tissue injury, adult congenital heart disease patients are at risk for a wide variety of conduction delays, as well as atrial and ventricular tachyarrhythmias. Pacemaker and defibrillator insertions, lead extractions, and generator changes are frequently complicated in the adult congenital heart disease patients who may have unusual anatomic pathways and stenotic or occluded veins. Epicardial lead placements are often necessary in single ventricle patients who have limited or no venous access to the endocardium. Supraventricular and ventricular arrhythmias are a major cause of morbidity and mortality in adult patients with congenital heart disease. So for these patients with atrial fibrillations or flutter undergoing open heart repairs, a right-sided maze procedure can be performed with the expectation of 93% freedom from arrhythmia. Minimally invasive approaches to arrhythmia surgery, such as the mini-maze procedure, may be difficult to accomplish in certain adult congenital heart disease patients because of the unusual anatomy and extensive reoperative scarring and adhesions. This may limit the exposure through the small incisions and the camera for the minimally invasive surgery. The Cox-Maze procedure for supraventricular arrhythmias in the adult congenital heart disease patients is often complex, and an alternative approach using intraoperative monopolar irrigated radiofrequency ablation. That is maybe better. Prophylactic arrhythmia surgery for patients undergoing congenital heart repairs should be considered for high-risk groups. Coarctation of the aorta. Primary and recurrent coarctation of the aorta in adult patients is usually managed percutaneously with balloon dilatation and stents. Surgeons may intervene if a device migration occurs or if there's a dissection or a rupture occurs, and occasionally to establish vascular access. When the transcatheter therapy is not feasible, surgical repair of the adults with the coarctation and the aortic arch obstruction is performed. Access is usually gained through a left thoracotomy, and the perfusion team is on standby for left atrial appendage to descending aorta cardiopulmonary bypass, just in case. Repair can be either a coarctation resection with end-to-end anastomosis, or an onlay patch and enlargement with tissue prosthetic patch, or a synthetic tube interposition. Aortic mobility is limited in the adult patients, and tension-free repairs must often require interposition grafts. Mortality for these procedures is rare, and follow-up 75% of patients will be normotensive without hypertensive medication. Interventional device management. Adult congenital heart disease patients may have intravascular devices in the aorta and pulmonary arteries, atrial and ventricular septal occlusion devices, and transcatheter stented valves. These are all considered interventional devices for the patients. Vascular stents are being effectively used in the neonates and infants, with the understanding that patients will inevitably outgrow the maximum size these stents can achieve. So these outgrown vascular stents are more commonly seen than re-operations involving septal occlusion devices. At re-operation early after stent implantation, within 3 months or less, it may be possible to completely remove the stent by chipping away and dissecting the cells using scissors. And the stent can be collapsed inwards and peeled away from the vessel wall. However, after 3 months, the stent is incorporated into the vessel wall, and embolization has already occurred, making the removal very difficult and traumatic. So the stent will have to be spread open like a bun to create space for an onlay patch. If the final vessel reconstruction does not achieve a full adult size vessel lumen, or if it's compressed by an adjacent structure, the patch split stent is a safe landing zone for future placement of an adult size stent. That was my topic, and thank you.
Thank you, Dr. Abdelhadi. Just one question. You mentioned something regarding pacemaker in Fontan Revision. I didn't get your point.
In the Fontan
Revision, yes.
Revision.
Yeah.
Yes, we mentioned it is a routine. It's recommended. It's recommended to insert a routine insertion of a dual chamber pacemaker to prevent antitachycardia that is occurring with the re-entrant pathway and the complex anatomy.
Okay.
These patients, because many of the operations occurred on the atrium and on the right ventricle, especially if it was an intracardiac Fontan with the enlargement of the right atrium, this will have arrhythmias and tachyarrhythmias mostly with the re-entrant pathway. So a pacemaker with the dual chamber is recommended.
Okay, thank you.
Welcome.
السلام عليكم. بس أنا ممكن أوضح النقطة هذه للفونتان ريفيجن بآيات. هاني وقتي معكم.
Yes, دكتور.
بس بالنسبة للفونتان ريفيجن recommendation to put a pacemaker, epicardial pacemaker for two reasons. For atrial arrhythmia, basically they get their incidence of higher atrial arrhythmia is very high when you do Fontan revision. So most of the time we do Fontan revision because we're converting an intracardiac Fontan to an extracardiac Fontan. There is so much sutures and dead tissue in the way. So if there was no atrial arrhythmia, you would induce atrial arrhythmia by the surgery. The second thing is that there is no access for the EP guys to put a pacemaker when you do Fontan revision. Once you do go from intracardiac to extracardiac, there is no way for them to get into the heart to put atrial lead. For putting epicardial pacemaker wires and implanting a device will help you and the EP guys to do whatever they want to fix the arrhythmia that happens later on in adulthood. One of the major issues with Fontan circulation in adulthood is atrial arrhythmias that happens because of the sutures and stuff like that. So it's better to put it when you do the Fontan rather than you bringing the patient in 6 months to 1 year to open their chest and just to put pacemaker leads. واضح؟
Yes, doctor. Thank you. Thank you, Abdelhadi, also.
Thank you.
Thank you, Abdelhadi. Any other question? Mr. Hani, do you have any other comment?
لا in general is very good. طبعا في أشياء في البداية قالها حميد بالنسبة للريسترنوتومي there are so many techniques. People leave wires, people remove the wires. As long as you get comfortable with what you're doing and you're ready. The most important thing is for sternotomy, for adult congenital, is that you have to know your anatomy. You have to know what is under the sternum. Sometimes it's the RV, sometimes it's the conduit. It's not like adult redo cabbages. Most of the time it's the RV that's behind the sternum. Sometimes when they have, and this is like a nightmare, when you have an RVOT stent that is stuck to the sternum. For all of my redos that have RVOT stent, that is, I do CTs routinely anyway for any redo, regardless of what the radiology say. I have to have a CT to know what I'm doing. Another thing is that if the stent is stuck to the sternum, it's not like the RV, you can dissect it out a little bit. Once you make a hole in the stent, the patient will bleed out. So for RVOT stents and or homografts, you have to have a CT and you have to have the pump ready. Sometimes people put wires in the groin so they can, I open the groin, but put the wires and leave the cannulas on the table ready to cannulate. And if you feel like 1% chance that you're going to injure this RVOT, might as well just go on pump, decompress the RV, and have the patient ready to go on pump. You can do the whole case through fem bypass with a beating heart if it's just RVOT replacement.
Thank you.
Okay, thank you, Dr. Hani. Thank you, Abdelhadi. Well, unfortunately, Dr. Haytham apologized for presenting his lectures today due to urgent operation. So if anyone from the next week lectures is ready to present, he can prepare his slide. Otherwise, we'll conclude the session. Just a few minutes. I'll try to contact next week presenters just to see if anyone is ready. So unfortunately, presenters for next week are not ready to present this week.